This conference will now be recorded.
So we are starting with emergency contraception, but today's class is going to be a little bigger because I have to complete 2-3 other topics as well. So I try to make it simple as much as possible. Hope that helps you. Okay. So emergency contraception. Uh, in UK, there are three options are there. One of them first is copper coil or copper T. Okay, and why it is effective? It has got more effectiveness than rest of these. Why it is there? So we'll be discussing that. So this is first option. Second option is ulipristal acetate, UPA or 11. Their brand name in UK is 11. Maybe in some time in exam you may find this 11 or part 3 people, you have to know this name of 11. So the dose is 30 milligram. Okay. Third option is Livonel. Livonel is levonorgestrel, and it is though it is 1.5 milligram, but here you can see they have it is in microgram strength, so it is 1500 microgram tablet. So these are the three options, those available in UK, what we for emergency contraception. Now, what are the where are the when we have to give emergency contraception? Okay, so whenever there is unprotected intercourse, everybody knows it. But if there had been a postpartum patient and first 21 days after childbirth, if she is having emergency unprotected intercourse, no need, no need to give any emergency contraception. If there had been an emergency unprotected intercourse within 5 days of miscarriage, abortion, ectopic pregnancy, GTD, no need to give emergency contraception. So when we give it, day 21 after childbirth, we would require to give her emergency contraception for unprotected intercourse. Day 5, so day 5 after abortion, miscarriage, ectopic pregnancy, and GTD, we have to offer her emergency contraception. And if she is using contraception, but some incorrect use is there, then also emergency contraception is required. So someone's mic is on, so please, Nikki, your mic is on, please off it. Then, so these are the indications for emergency contraception. And in exam, you will find question from this part. So she has a childbirth. Today is after 19th day. She has an unprotected intercourse. She has come to you. So what you will give? So your answer will be reassurance. Okay. This part everybody knows, but you learn this if you don't know beforehand. Then this thing is important to understand. Okay. So when if the patient is on like combined hormonal contraception, so usually we all whenever we give them, so it is for 21 days active, then there will be a week off for 1 week, 7 days off is there. Okay, so sometime so this is the regularly we give, everybody knows it. But what happens if the patient is coming and she does not she has extended this hormone free period. Hormone free period is HFI. Okay, so what the research shows that after last pill what she has taken, ovulation can be in at the 8th day after last correctly taken pill. Okay, so what they are saying, so either she has to start the pill the way she has been told, but if she has not started the pill, so after last pill, ovulation earliest possible is within 8 days. Okay, this part is important to understand. You will get to know why. And so if we expect ovulation at 8th day, so copper T will usually provides protection 5 days after emergency sorry UPSI or unprotected intercourse. So like after if we add this 8 and 5, that is 13 days. So you will find in guideline that if the patient is taking CHC clearly, but now she has missed it or she has delayed it. So from last last pill she has taken till 13 days, she can be offered IUCD as in contraception, because what they say that implantation will occur usually 5 to 6 days after ovulation. So after according to this, what the guideline says, after after last pill, earliest ovulation will be there for at the 8th day of the after 8th day, and copper coil we can offer till 5 days. So 8 plus 5 is 13th day. So if any act of unprotected intercourse had happened in this period, so copper coil could be considered as an option for her. Okay, why understanding of this is important? Because in emergency contraception guideline there is a table. In that table always they are saying copper coil can be inserted uh, hormone free 13 days after the last pill taken, or within 13 days of hormone free interval period. So therefore why they have set this limit of 13 days, so it is important to understand. So I think this thing will be clear to all, because if you understand this, then only that table will be, you will be able to understand. Is it clear why they have said this? Is it clear?
Ma'am,
Okay, fine.
Uh,
So it is clear that,
I'm sorry, I
yes, yes,
point now. I just want to know
yes.
if this is the first time.
what is it? 5 days?
uh, should I explain it again?
Yes, ma'am,
Ma'am, I
please.
didn't get that 5 days.
Okay, okay, I'll
Yes,
explain
please.
that. Yeah. Okay. See, so I'll just give you an example. Say, for example, what in CHC, combined hormonal contraception, usually how the thing works. So we give hormone for 21 days. Then usually there is a hormone-free period for 7 days, and then again like from first day or from fourth day, next cycle again cycle is started. So this is a normal thing we advise to patient if she is taking CHC. Okay, but now what they are saying, that if the patient has to start CHC 1 week after, for example, she has finished last Sunday, so today Sunday she has to start it after 7 days, but she is not doing that. So uh, eight, 8 day after she has taken last pill can be ovulation. That means if she has taken last dose last Sunday, okay, so today Sunday is 7th day, so tomorrow is Monday. On Monday there will be 8th day, she has not taken any hormone pill, so earliest ovulation can be there till 8th day after last pill. Okay, so this is this 8 day, and we already know that copper coil is effective 5 days after ovulation. Okay, so this 8 plus 5 is 13 days. So therefore you will find in guideline that if hormone free interval is up to 13th day, then copper coil can be offered as an emergency contraception. Now the thing clear? Okay, okay, very good. So this, yeah, only you have to understand, no question is coming from here. Okay, there will be no question, but yeah, understanding is important. Okay, good.
Excuse
Now,
me, Dr. Excuse me, Dr.
yes,
Priyata.
yes,
Sorry.
yes.
Can you explain again, please? Sorry.
No, it's fine. So, yeah, so actually, what guideline says that if the patient is on CHC, so now if she finished CHC last Sunday, that there had she has taken last tablet. So, what the guideline says that within 8 days of hormone-free interval, when she is not taking any pill, ovulation can happen. Fine. So like if she has taken last pill last Sunday, so this Sunday will be 7 days plus one day is Monday. So like
Right.
within 8 days ovulation can happen. And you already know from your knowledge or that copper coil is effective emergency contraception for 5 days. So that 8 days of hormone free interval where ovulation can happen plus 5 days of days of after days of ovulation. So this is 13 days. So what the guideline says, so if there had been 13 days after hormone free interval, or you can say if there had been 13 days after she took last CHC, copper T or copper coil can be used in emergency contraception option can be given to her. Now the thing's clear.
Yeah. So another also there is a description that IUCD we can use after ovulation, but that means 14 days. From 14 days to that 5 days. That means 14 to 19 days we can
Yeah,
use for IUCD,
I will
isn't it?
that also. Just wait.
Yeah.
Okay. Yeah.
Yeah. Thank you very
I
much.
will tell you, I'll clear everything. I'll clear. Okay. So
Okay. Okay.
this is the scenario when patient was on CHC.
Okay.
Is it
Yeah.
clear? Yeah.
Yeah. Thank you.
Now, this is a table of your of guideline where the guideline tells you if she is on what type of contraception, if what mistake she has done, till when, and what type of emergency contraception can be offered to her. So this is the picture from guideline, but this appears to be very, like, what should I say, very complicated. Now I have summarized it here. So this is the summary. Now I think this will be more easy. So if the now you will get a question, patient is on either she is using patch we already know, CSC patch or Evra name is Evra, or she is using vaginal ring, that is a newer ring. So if there had been like up till 48 days, 48 hours, if patch is removed or ring is not there, there is no issue, ovulation cannot happen. So she's not at risk. But if there had been more than 48 days, either a patch was removed or patch was like it was partially attached, or ring fell off, something had happened, and there had been more than 48 days for sorry for that 48 hours. Now if this scenario comes, what will be your answer? So this is your answer. For this patient, you have to consider emergency contraception. Second, now emergency contraception are three. So usually, a first line like is copper T, but copper T can only be offered till 13 days of hormone-free interval. This 13-day thing I have explained in details. So till 13th day after last contraception CHC she has taken, so copper T can be inserted. So so this is one. Second, LNG. Third is UPA. But what we consider here, so we can consider LNG. Why we consider LNG? LNG is levonorgestrel and UPA is ulipristal acetate or 11. So first option will be LNG. Now why it is there? So I will explain it. So ulipristal acetate is, it is a progesterone receptor modulator. What that means is that some of receptors in the body, it have agonist effect. Some of the receptors it will have antagonist effect. So if the patient is already on any kind of progesterone containing contraceptive, for example, you already know in this patch and in this ring, progesterone is there as a component. So as the progesterone was already there in the patient's body, now if we give UPA, so it will be, its effectiveness theoretically will be less because of its different mechanism of action. So the better choice will be levonorgestrel. It is only because it has got no that antagonist effect is not there, so it will be only progesterone. So if the patient is taking progesterone only, and if you are giving progesterone pill, so it will be considered to be more effective in this. So any condition, if the patient is already taking progesterone in any form, and if you give this UPA as emergency contraception, so it will be theoretically less effective, or it will be less effective because of its progesterone modulator action. Okay, so this is the explanation what I have said. So now these are the option if there had been detachment of patch and ring more than 48 hours. First of all, you have to consider EC. Second, you can give option as an LNG. UPA usually you will not give because of its less effectiveness theoretically. And if there had been 13 days interval after last hormone contraception, so within 13 days even copper coil can be inserted. So these are the options. So you just remember all these, and you will find it is not difficult to remember also, because many of the whatever the table we will be reading, so these option will be like the same, or we will change something. Okay, so this is the with this slide your answer will come if there had been removal for more than 48 hours. Is the thing clear? Then I move ahead.
Yes, Dr. Priyata, it's very clear. Thank you.
Very good, thank you. Okay, now another, there had been a table in emergency contraception guideline. So I have broken them in every box in one slide, because I have to make you people understand. Now another scenario, your patient is taking CHC, POP or implant. These are the three things that has been affected by enzyme inducers. So now what will, if patient is taking this and on enzyme inducers, so and patient has she is she's on enzyme inducers, and she is not taking additional precaution for 28 days, and she has an unprotected intercourse, then what will be your choice of options? So copper T, usually it has to be first. Copper T we use as a first line. Second, you can give her double dose of LNG. Okay, because patient is on enzyme inducer, so enzymes are induced, so you have to give double dose of LNG. UPA you will not give here, because UPA has got interaction, and double dose of UPA is not advised. Okay, so if say this type of scenario is there, your answer will come from here. So patient on CHC, POP and implant, all three affected by enzyme inducers, and your patient is not taking any additional precaution with it. Ideally, we have read in last class or first class, when the patient is on enzyme inducer, they have to use additional contraception for 28 days. Now, if your patient is not doing and she has got emergency contact, so these are the options. Number one is copper T, number two is double dose LNG, and UPA will not be used. So if you can remember this, your answer will be clear. Is it clear, people?
Yes, yes, Dr. Priyata.
Yes.
Please.
Okay. Now we have read this in first class also, when we were doing COC, and then when the two pills were missed. Okay. Now this is from the guideline, and this is the summary. So now your patient is taking COC, and she is on the first week, first 7 days, and she has missed two pills. So what are your options? Now options, it is same as just we read in the first slide. You have to give consider in first week if more than two pills are missed, so we have to give them an emergency contraception. What will be choice? So if we can consider LNG, because as the patient is already taking progesterone, so in this particular situation UPA will be less effective, that I have already explained. And if it is within 13 days of hormone free interval, then even copper T can be offered to her. So the options are just same what we have read in first slide. Is it clear? Is it
Yes,
clear?
yes.
Now, patient is on POP and missed pills. Okay. So this is the summary. This we discussed last class also. So if the patient is taking traditional pill we already know that is LNG pill. So and patient has been late by 3 hours or 27 hours last pill. This is first thing. Second thing, if our patient is taking desogestrel, we already know with the desogestrel ovulation is effect suppressed in 97% of the cycles. So it has got a larger window of 12 hours. This is recalled from the last class. So like if she has been late by 36 hours from last pill, desogestrel pill, then in this particular scenario she has to take this emergency contraception if OPSI has happened. So again your choices are same because this is a progesterone. So either you will offer CUT up to 5 days, okay, that you already know, or you will offer LNG. UPA you will not offer her. Why? Because it will be less effective, because the patient is already taking progesterone as a pill. So UPA will be less effective. Okay, so this is just an POP missed pill summary. Is it clear?
Yes, clear.
Yeah. Now this is with the DMPA injection. So now what is the summary of what I made is this. So if the patient is taking Depo-Provera injection, then so usually after every 12 weeks this injection is changed. But if your patient is has not come up to 14 days, okay, up to 14 days she does not require anything. But if 14 days are passed, okay, already over, then and she has got intercourse in first week after late injection, then in that particular situation you have to give her EC. Again your choices are same. CUT can be done till 5 days. LNG you can offer because progesterone UPA will be less effective. So this part you have to know. Someone in I don't know, one of you has sent one picture in last Sunday. They wanted to know about this progesterone DMPA. So this is the answer to that. So if you can remember this, then your answer will be done. Okay, so this is a summary of that. So after 14 days, so if the patient is coming with UPSI, then you first, if UPSI is there within first 5 days, offer copper T, or otherwise LNG. UPA will be less effective. So that will be either we will not offer it, or it will be kind of third line, last line. Okay, so this is the progesterone summary. You will get question from here this, that patient has come 14 weeks 1 day, 14 weeks 2 day, what to do? So answer will come from these options. Is the thing clear?
Yes. So the safest option in all these things is copper IUCD, and the next comes the LNG, and UPA is definitely not recommended because of the interaction. That's right, Dr. Priyata?
Yes.
Okay, thank you.
But
Ma'am,
your
I want to know, ma'am, I want to know something.
Mhm. Yeah.
Hello.
Yes,
Uh,
I'm speaking.
After progesterone injection, is it the
Mhm.
same like ovulation occurs after 8 days or CHC?
No, it
After
is for
DMT,
CHC
I
only.
think the ovulation is much longer,
No,
much later.
that was for
So
CHC
how
only.
it
That was for
functions here?
CHC. That was
For
for
this,
CHC.
okay. Here, like if she hasn't taken her injection for more than 2 weeks
Yes.
after the last injection, so how
Yes.
will we calculate the days?
You need not to calculate. It will be given
Just
in
we
the
have
exam.
to use, like we are using LNG. So
Yeah.
how does it? I was like correlating it with CHC, so I wanted to know a little bit more clear.
Okay. So uh, please forget CHC. That 13 days 8th day ovulation was with CHC only. Okay, please don't confuse with that. This is totally different. DMPA, you already know that DMPA, like it causes suppression of ovulation, and after DMPA, when will be the ovulation? Actually, you know, it is not given in the guideline, and it is, I think it is not predictable also, because there is delay in fertility after Depo-Provera up to 1 year, that you already know. So for their guideline, just for your knowledge, like what they says, if she is coming more than 2 weeks late, then it's fine, because according to them that period will be protected. But if she is coming after 14 weeks and she has got emergency, she has got that intercourse is there, then in that situation you have to give her emergency contraception, and first choice always is copper T if it is falling in your prerequisites. Second choice is UPA. In all other situation that where patient is not taking any hormone. Okay, and third is LNG. But here, as the patient is taking progesterone already in her body, so first choice will be CUT, second choice will be LNG, UPA will be less effective, that you already know. Is the thing clear now, Ragini?
Yes, yes, thank you.
Ma'am, one thing. Now
Yeah.
we have, yeah, just generally talking, we have stopped. She has missed 2 pills in the combined hormonal contraception, and it's time for her to take emergency contraception. Shows she takes LNG. And what about the rest of the contraception? Like after taking LNG, should she continue with her CHCs?
Yes, that part I have told in first class. So she what I have shown that option slide last class also. I have shown them. I think this is there. So this I have shown in first class. I think you missed. So this is the summary.
Sorry, I was not there.
No, it's fine. No, it's fine. I'll repeat it. So if a patient was on CHC and she missed 2 pills in first week, so like what she has to do, she has to take EC plus 7 days additional contraception, and she has to continue rest of the pills. Okay, so in this situation your answer will be EC plus 7 days additional contraception plus continue rest the pills as routine. Is it clear?
Okay, so she takes EC and she also takes her combined hormonal contraception also on that day.
Yeah, she will continue rest pill. She will continue
Okay.
rest.
Yeah, and for the next 7 days, additional contraception.
Yes, additional contraception is required next 7 days.
Okay, ma'am. Thank you.
Yeah, this I told in details in first class.
Okay, ma'am.
And
Okay, thank you.
and if you like, I have sent link to first class also. If you wish to listen that again, so I'll
Oh,
resend that.
definitely. Yeah, definitely. Thank you. Yeah.
Yeah, fine. So now this
Dr. Priyata,
yes.
I had that last time I asked you about multiple episodes of IPSI. 14 weeks one day, and she had multiple episodes, and multiple episode less than 5 days ago, and more than 5 days ago. So there are things like more than 5 days ago or less than 5 days ago, and that time we will give EC. If the episodes are this, I had doubt actually, that last column of the table with multiple UPSI.
So if the multiple IPSI is
Sent
there,
the snapshot of the table again. I have sent it just now.
okay,
This
I'll
question,
discuss that. I'll read it again. I'll discuss that.
Okay,
Okay,
thank
and
you.
this which guideline? Because this I think is old guideline.
No, Dr. Priyata, this is the new one. It's in the injection, DMPA injection form.
Injection. Okay, I will see.
Yeah.
I'll go through this again. Yeah. Then I'll
Because this
explain.
time they asked about this multiple episodes. They asked about this multiple episodes of UPSI and what you will do next. That's why I wanted this clarification. Thank you.
Okay. Okay, I'll do it. I'll just read it again because I was not. I thought you were sending this part, second post slide. I was not able to get it from the this thing from group. I'll just explain it to you again. But till now, just keep learning this thing. Just understand this thing. Then that also I will explain. Is DMPA thing clear? Should I go ahead?
Yeah, this is clear. Thank you. Yeah.
So she takes LNG and immediately she takes the next dose of DMPA, ma'am.
Yes, she has to do. Because this is emergency contraception, this will protect for 1 act. Okay, this is again last part of the table. So what they are saying,
if she will
yeah,
take the copper IUCD, then she can continue that one as a contraception as well.
yeah. The copper coil can be if she wants to continue it, she can continue as ongoing contraception, and or if she wants to remove it, so it can be removed once she has period. And if she has taken oral contraception, oral EC, then you have to ask about ongoing contraception as well. That part will come. I will just explain you.
Yes, thank you.
Yeah. Now another this table I find more difficult. Therefore I am explaining every part of it. So now the patient has IUCD or LNG IUS. Now the patient either this has like expelled, or it is partially expelled, or if the threads are missing, or if their location is not known. Now how the things to be taken in that situation? So you will ask this patient, okay, if she has got intercourse 7 days before, after this lost IUCD or expelled IUCD, then you have to give her emergency contraception. Okay, if she has got intercourse last 7 days of copper T removal, then you have to give her EC. Okay, and what will be the choice of EC? If she has intercourse last 5 days, then UPA or the copper coil can be offered to her, and last 3 days LNG can be given to her. Okay, so they if we have removed copper T today, today is Sunday, we have removed copper T today, but if in last week she has intercourse, so we have to give her emergency contraception. Is it clear? And if she has intercourse last 5 days, then UP or copper T, anything can be given. Is the thing clear, people?
Yes, clear.
Okay, so
Hi,
now the
but
easy.
sorry, Dr. Priyata. Now, if
Yes.
the location is unknown or if it's IUD is missing, then how can we offer the IUD if we don't know where exactly it is?
Yeah, so in that, okay, they have, it is not according to scenario, it is just in general thing. So you will find
Okay.
from your question that patient, if they say copper T fell off, then you can put it there. But if they say copper T is inside the abdomen, then you can't give copper T again, then you will go for UPA.
UPA. Okay.
This is just
Thank you.
general thing, yeah.
Okay, thank you.
Okay, so this you already know. So copper IUCD is the best one. It is the only one thing that can be kept for ongoing contraception. And first 5 days, like within 5 days, a copper coil can be given. Now someone was asking, let me explain you. So in normal cycle, if we consider date of regular cycle of 28 days, okay. So 14th day is an ovulation day, and with usually if the pregnancy happens that day, okay, then implantation will occur usually within 6 days, 5 to 6 days. So they are taking that as a limit because copper T is in contraception that has got effect on implantation also. It does not allow implantation, and implantation usually occur within 6 days. So they are taking that 5 days of implantation in the picture. So what they are saying, if only copper T is emergency contraception that can be offered 14 days of 14th day of ovulation plus 5 day that is up to 19th day of over 19th day of regular 28-day cycle, copper coil can be offered. So someone was asking that question. I think now it has been cleared. Is it
Yes,
clear?
thank you. Yes, this is the one. Yeah, thank you.
Now, so this is one. Second is LNG. LNG is 1.5 milligram single dose contraception, and it within 3 days it can be taken. Fine. Then another one is UPA or L1, that is progesterone receptor modulator. So it is 30 milligram single dose, and it is licensed up to 120 hours or 5 days. Okay. This part I'll be explaining again. So these are the options, these are the doses, and these are so you can sometime you will get only this question that ulipristal acetate is what actually it is what. So you will answer this question, progesterone receptor modulator, though it appears it is simple thing. Now this why I have put it, because sometime in some stem of SPAs you will find that UPA's method. What is this USIP method? What is this method? Previously, when emergency contraception, like unprotected intercourse is there, they used to give 2 doses of COC together, okay, as an emergency contraception. So name of this method is USIP method. So you just to know that you should know this, or what is this USIP method. Therefore, I have just put this slide because in many STEM you will find in SBA this method. So you have to know this. Now, sometime copper coil is the ideal contraception for them. So now the patient has come.
Can we use that any kind of contraception for use method?
No, it was given previously. This is not recommended now. Only I have to explain this. Therefore, I have put this in the picture.
Okay, okay.
We are not giving that. We are just only this. This is the choice options we have. You have to remember this only.
Okay, okay. Thank you.
Yeah. Now your patient has come to you and she said, doctor, I want to go for copper T as an emergency contraception. Then and you are not in a position to fit it. Okay, then you will not send this patient back. At least you will give emergency oral contraception. Okay, so sometime you will get in a question, okay, what copper T cannot be fitted today, she wished for copper T, what to be done? So one option will be referral, one option will, and second option will be give oral EC and refer her. So answer will be second, give oral EC and then refer her. So therefore it is important, if you are not able to put copper T today, please give her an oral OC and then refer her. Now, ongoing contraception. So this is all about ongoing contraception. So if the patient is taking copper coil, then copper coil can be offered as an ongoing contraception if she wants. Otherwise, it has to be removed next cycle. And but if the patient is taking oral EC, UPA, LNG, IU, LNG, in that situation you have to explain her. So this will protect only this episode of intercourse. So if she wants to go for either till next period she has to avoid sex, or she has to use ongoing contraception. Okay, because that will not protect for any other act of intercourse. When in part 3 we do station, we always put this ongoing contraception in the answer. Now it is very important to know copper T as emergency contraception. So there are few. So for primary mechanism that it has a toxic effect on sperm and ova. So usually the fertilization it prevents this fertilization, and if fertilization happens also, so it causes inflammatory changes in the endometrium. So it prevents implantation also. So now copper T is only one contraception where pre and post fertilization mechanism of action is there. Okay, so this part you have to know. So it affects on fertilization as well as it affects on implantation only, Because of this mechanism of action, it is considered to be the number one or best method of emergency contraception. Again, someone asked me this question, so this is the answer again here. So usually implantation will occur within 6 days of ovulation. So copper T can be inserted up to 5 days of ovulation, that is 19th day of regular 28 days cycle. It is important to know this mechanism of action of copper coil, because you will get this as in your question also. Now, what is the UPA mode of action? This is also UPA and LNG, they are emergency contraception, and but UPA is considered to be better than LNG. Why it is better? So this you have to understand. You already know this ovulation. So first of all, there will be starting of LH surge, and there will be LH peak will be there, or LH surge will be there. Then there will be ovulation. So what is the difference in the mechanism of action? So usually ECA, UPA, it mechanism of action of both of them is that they delays ovulation, but UPA delays ovulation even after start of LH surge. So now if LH surge has been already been started, then also UPA will be able to prevent this act of ovulation. But and if the peak is already there, that means if surge has been passed and you are giving them a UPA, then there will be of no use, because if the LH surge has happened, then ovulation is going to happen. So oral contraceptive, either UPA or LNG, they will not be able to prevent this action of ovulation. Okay, therefore oral contraception are not effective if they are taken after ovulation. Okay, so like if your question comes, so patient has come on 18th day of cycle and she has regular cycle. In that situation, oral copper coil will be an option, because it is not possible to give oral contraception, emergency contraception, because they will not be effective. So this you have to understand, that no oral EC will be effective after ovulation. So this is one thing. And UPA is more potent because it can prevent ovulation or delays ovulation if it is taken at the start of LH surge only. So at this point also, if the UPA is taken, ovulation will be inhibited. But the same thing is not for LNG. Okay, so LNG inhibits ovulation, delays and prevents delays or prevent follicular rupture, causes luteal dysfunction. But you have to take the patient has to take this LNG before even start of LH surge. Okay, so this LNG will be affected in this part of the cycle. So once surge started to happen, then LNG will not work. At this moment, UPA can work. Therefore, UPA is caused as a better emergency contraception, more potent emergency contraception than LNG. Is the thing clear about mechanism of action?
Yes,
Yes,
Doctor.
very clear. Thank
Okay, so UPA copper IUCD is most effective. UPA can be given 5 days, up to 5 days of emergency, UPSI, and it is more potent. I have explained why it is more potent. LNG up to 3 days, and oral EC will not be affected after ovulation. Now this thing is clear. Move ahead. Now if you are getting this high BMI patient, and there are 3 options. So copper T, this is not affected by BMI. UPA dose is not affected by BMI. But if the patient in your question is more than 70, either part 2 people or part 3 people, in part 3 also we always ask BMI of the patient. No station can be done without asking BMI. So we always ask about the weight of the patient or BMI. So if in your question it is more than 70 or it is BMI more than 26, LNG double dose has to be given. So only one EC that is affected by BMI. Enzyme inducers relation copper is not affected, that you already know. UPA is affected. Therefore, if the patient is on enzyme inducer, we cannot give UPA. We can give LNG. LNG has to be double dose. Okay, this part has been repeating again. Now, interaction with progesterone, this part I have already explained, but I will still again explain that if the patient is taking any progesterone in any form, so if the UPA is given because of its modulator action, so it will be less effective. Okay, so this is not proven, but it is theoretically less. Then copper T, copper T, somebody's mic is on. Vicky, please off your mic. So this part is very important for both part 2 and part 3 people. You have to know this and remember this table. Okay, what is category 3 for copper T? What is category 4 for copper T? Because you in for part 3 people, usually a station comes where she will want copper coil as an emergency contraception, and her category is 3. So that is a sort of a tricky station. Therefore, it is important to know the category. So if the copper coil is inserted after 21 days till 4 weeks, okay, so it is category 3. Complicated organ transplant is category 3. Patient having long QT interval is category 3. Decreasing HCG level, that means patient had mole but now they are decreasing, so it is category 3. This part is very important for all of you. Radical trachelectomy, you have to remember this. Radical trachelectomy or any cervical treatment, it is category 3. Usually this indication is coming in the part 3 station, so it is category 3 there. Distorted cavity, okay, it is category 3. Asymptomatic chlamydia, that means patient has chlamydia is there but patient has got no symptom, that is also category 3. Because if the patient has symptom or symptomatic chlamydia or gonorrhea is there, that is category 4. And pelvic tuberculosis, if you continue this now, if, like patient had uh, pelvic tuberculosis, she has copper coil already in situ and it has been diagnosed and she wants to continue it, then it is category 3. CD4 count is less than 200 and if you want to put it inside, that is also category 3. So nothing to understand here, but you have to kind of remember it very well, because in part 3 direct question, one of this, they will give scenario from one of this and she will want copper coil as in contraception and you have to kind of explain her. Part 2 people question can come. This is category 3. This is category 4 for CUT. It is easy to remember. Like any sepsis, we already know in sepsis we will never give postpartum post-abortion sepsis. Current PID we will never give. Symptomatic chlamydia, gonorrhea we will never give. So these are all infection, active infection. Why we will put anything inside uterus? We are going to perforate it. Remember this way. If pelvic tuberculosis is diagnosed right now and if you are inserting it inside, it is category 3 because the walls may be fragile because of that tubercular thing and you are going to perforate it. The cervical cancer patient waiting treatment, there will be perforation if you do it, so it is category 4. HCG malignant disease, choriocarcinoma patient, and if you are inserting copper coil, it is going to perforate. Endometrial cancer already, current chlamydia and gonorrhea. So these are the category 4 for copper T. So these are easy to learn, because you already know this will be category 3. So you have to remember this category 3 table. Nothing more to be one important. Usually I have gone through that UK MAC category. So usually there were all category were 1 or 2 for emergency contraception. This part you have to remember. So if the patient is taking, if patient is asthmatic, you will get a number of questions from there also. If the patient is taking is asthmatic and she is on glucocorticoids, and you she has come to you, and you have to give her emergency contraception, please don't put as UPA here. Why? Because it has got a glucocorticoid effect. Her asthma is going to worsen. So you have to whenever in part 3 stations, whenever we take emergency contraception station, we always ask this patient, any treatment for asthma? If she says yes, this option is already gone. So you have to remember, this is important for both 2 and 3 people. Now, breastfeeding relation is also important to understand. Copper has got no problem, LNG has got no problem. But if your patient is breastfeeding and she has chosen UPA, then in that particular situation, she has to express and discard milk for 7 days. This comes as a question also, this stem. Then this part is important, sexual assault and EC. So when any kind of sexual assault has happened, usually we have to offer her, this patient, an emergency contraception. And in this particular station, scenario, it is not, you will say, no, 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 I will not give property, you know, because of this unprotected intercourse assault has happened. No, all options of emergency contraception can be offered for patient if she has any assault is there. Okay, but you have to take care. What copper coil can be given, you have to offer her antibiotic cover for STI. Now, this is number one. Second, this is also important because sometimes you will get this type of question. If she wants to go for forensic examination, they're like all samples, rape samples are collected in early evidence kit. Okay, if she wants to go ahead, she says, okay, I want to go for sample collection, then in that particular situation, her clinical examination and property insertion will be deferred or delayed till forensic examination sample has been done. Why? Because if we do this before, so it will interfere with the capture of DNA of that salient. Okay, so sometime you will get question from here also. So things to remember from here, all options can be offered for sexual assault person, and copper IUCD can be offered, but you will offer antibiotic cover for STI. And if she goes for forensic examination, then you have to kind of delay it or defer it until all sample collection in early evidence kit is there. So you may get question from this slide, a number of questions. Now this important thing. So if this patient has a unprotected intercourse, or she has taken emergency contraception, now she has got another episode of it, so can it be given again? Yes, both of the UPA or LNG, it can be offered again in the cycle. But few things we have to remember, that if the patient is pregnant because of previous intercourse, and you are giving this again, LNG and UPA, you are giving this again, so you kind of say to this patient, if you are pregnant from previous act of intercourse, and if you take this emergency contraception again, then it will not do any harm to your pregnancy, or it is not associated with any fetal abnormality. This part of assurance we give to the part 3 role player patient. Okay, so it is not going to affect your pregnancy. If pregnancy happens, so you can continue with it. Okay, so you have to kind of assure this person. Now a few
Excuse
things.
me.
Yes.
Yes, excuse me, doctor. Can you explain this one again, the pregnancy, that one, please?
Okay, so now if the patient has intercourse, and she has taken emergency pill. Okay, again she comes back to you after some days with another episode of intercourse, and now she again wants that pill. So there could be possibility she can be pregnant from previous intercourse, previous episode. Okay, previous episode that had happened in the same cycle. So now she might be afraid that, okay, if there is a pregnancy and I'm taking this pill, what will happen to my baby, doctor? So your answer will be
Mm.
oral. This pill, oral pill, both of them will not have any harmful effect on the pregnancy. It does not cause any fetal abnormality. So if she found herself pregnant after oral EC, she can very well continue with that. Is the thing clear?
Yeah, but if she tell that no, I'll continue the pregnancy, so then she can stop the emergency contraception, isn't it, and continue the pregnancy if she wants to
Yeah, if she
continue.
wants to continue, it's fine.
Yeah, then she'll stop the emergency contraception.
Yeah.
Yeah, yeah. Thank you.
Okay. So
Ma'am,
now, yes, yes. Yes. Someone was asking question. Yes. Hello.
hello,
Hello. Yeah.
ma'am. If she has taken EC
Mm-hmm.
already, can it be repeated in the same cycle?
Yeah. It can be. It
Like
can.
she has taken in the 10th day, and she has
Yes.
taken 10th day. So
Yeah.
ovulation can be delayed up to 5 days. No, can you clear
No.
it, ma'am?
So yeah. So how much? How if this patient takes oral EC, how many days it will be? Periods will be like ovulation will be delayed. That is like it is. It cannot be predicted. So how much
Okay,
delay is
ma'am.
this? It cannot be predicted. So now if on the like on the 7th day or 8th day of cycle she has taken oral pill, 3 days after she
Okay, ma'am.
again comes back, doctor give I have got another episode, so I want to go for oral, so you can give her.
Same LNG can be given, or UP also can be given.
So this I'm just going to
Same EC or
I will just
hello?
explain it. Just
Okay,
wait.
ma'am. Okay, ma'am. Okay, ma'am.
Yeah. So like what you will say. So ideally if the patient has taken UPA, so she should take UPA also. Again, why? Because if the UPA has been taken as an emergency contraception, after UPA till 5 days usually no hormone is given because of this its modulator action. So ideally what they want to say is, if UPA is taken on the sixth day of cycle, so and she's coming after 5 days, then UPA ideally ideally you should give UPA. LNG is progesterone. It should not be given because it will not be affected. Okay, because of its modulator action. So after UPA, we never give any hormone till 5 days. Is it clear? After UPA, we never give any hormone till 5 days because of its modulator action. So either if the
Yes, ma'am.
girl comes, yeah, either if she says I would like to go for LNG, so you have to say it will not be effective, or or you can give same option. So if she has taken UPA, she can again take that. So it can be taken 2 times. So this is with the UPA. Another thing. Now come here. If the patient has taken LNG and now she wants to say, no, doctor, I will go for UPA, then you have to say, if you have taken progesterone before and it is 7 days before, then UPA will be less effective because of this modulator action. So all these thing are there. So if she has taken LNG, so a UPA should not be given for at least for 7 days. And if she has taken UPA, then progesterone, any hormone, progesterone, LNG, it should not be given following 5 days. Following UPA 5 days should be given. So this appears to be confusing.
Then,
So
so after, please can you clarify? So if she's taken UPA, then we can repeat UPA, and that should be
yes,
done only after 5 days.
after UPA she can take UPA again, but if she takes LNG, she has to wait for 5 days. Same
And
pill can
UPA
be
can be repeated after, because its action is there for uh, how many days? So when can she repeat UPA again?
repeat any time. She can repeat any time. It is not like that. Same pill can be repeated. Same pill can be repeated. There will be interaction. It's changing the pill. Is it clear?
So I have one more doubt here. As an emergency contraception, she has taken UPA. Now she wants to continue her combined hormonal pills. So she has to wait for 5 days before she starts the pill.
Yes. Yes, that slide is going to come. She has to wait. That slide is
Okay.
just going to come. Yeah.
Okay.
All of you,
Ma'am,
please mute. Yeah, yeah.
ma'am, if she has taken UPA or LNG on 10th day,
Yes.
her ovulation postponed to 19th day,
No,
14th to
no.
19th day.
Okay,
Is it
that
not like that?
no. After UPA
And
or
again,
LNG,
she has UPA on 20th day. Which one will be effective, ma'am?
see, at 20th day, like ovulation is already there. If she has regular cycle, then
Yes, ma'am.
oral EC is not effective at all. So at 20th day, you can't offer her anything. Till 19th day, copper T, before ovulation, oral. Is it
No,
clear?
ma'am, her ovulation is delayed because of that previous
Yeah.
EC, no? Is
But
it not
that
like that?
no, we cannot predict how much it is delayed. We cannot
Okay,
predict
ma'am.
that. Yeah, that prediction
So,
cannot be done.
so we can't offer any EC
No,
20th day.
no.
Okay. So she has taken UPA on 11th day. And then immediately next day she had another UPC. So again she has to repeat UPA?
Yes.
Okay, ma'am.
Yes. Okay, now I should move ahead. So usually you will get this also as a question. What are the side effects of this oral contraception? So she may have vomiting. If the vomiting is there within 3 hours, she has to repeat EC. Second, she may have menstrual disturbance. Third, there could be possibility of ectopic pregnancy. But if pregnancy happens after oral EC, so there will be no fetal abnormality. So she can continue with this pregnancy. Okay. So from here, the important line is number 1. So if vomiting is there within 3 hours, she has to repeat it. So coming to ongoing contraception, so if she has taken copper T, so it can be kept as ongoing contraception. Now, if she has taken LNG, so she can immediately start any kind of hormonal contraception. But on the other side, if she has taken UPA, so she has to wait for 5 days till she starts for any hormonal method of contraception. Someone was asking this question, so this is the answer. So with the LNG, immediate start of hormonal contraception can be there. With UPA, she has to wait for 5 days, then only another method of contraception can be started. Now this is also important. So if we already know, if the any contraceptive method is not started within first 5 days, and it is started on any other days in the cycle, then additional contraception is required. So with CHC, she has to take additional contraception for 7 days, but with POP, she has to take additional contraception for 2 days only. Okay, so this part we have discussed before also. So if because with the emergency contraception, usually it will be started any other time in her cycle. It will not be in first 5 days. So she would require emergency contraception, and this is 7 for the CHC and implant injectable, but it is only 2 days additional contraception for POP. Okay, this part you have to remember. Then another, what is the aftercare of emergency contraception? If patient has taken emergency contraception, that is oral one, or even the copper T also. So, and if her period delayed by 7 days, what will be your advice? Please do your urine pregnancy test. Okay, this is important. Now, this is a table from the guideline, but it is very, confusing thing. So, if you, so whole sum of this table will be only this. So, if she has got previous episode of intercourse, previous episode of unprotected intercourse, and her current episode is less than 5 days, so you can offer her copper T. But if she says, like, she has previous episode and now she said, I don't know anything, in that situation what you will do? So you will, first of all, you will check her pregnancy. She could be pregnant from this episode also. Then if pregnancy test comes negative, or you have ruled out pregnancy, then in that situation you can offer oral EC. Why you are offering her oral EC here? Because if she is pregnant from previous episode, then then in that particular situation, if she takes oral EC and later on pregnancy comes positive, so she need not to, like, if she continue with the pregnancy, that would be an option. Because right now, intercourse, when it had happened, she doesn't know. Again, this is the same sum up of this slide. So if the UPC is there at less than 5 days, if it is less than 5 days, then you will offer copper IUCD. Okay, but if she doesn't know anything, okay, when the last intercourse had happened and she came to you, so in that situation you can kind of offer her oral EC. Okay, so this is only some of that picture. Now this is also a picture that is very confusing picture, but all sum up will come from this slide. So if you can remember this, all answer will be done for EC. Now if the patient has come to you and she has got less than 5 days of emergency unprotected intercourse, so your option number 1 will be copper T, because it is best. You already know, because it has got pre-fertilization and post-fertilization effect also, but it has to be within 5 days of ovulation, that is 19th day of regular cycle. Second option that you can offer to this patient is UPA. UPA is that ulipristal acetate. In that situation, she has to start hormonal contraception. Ongoing contraception can be started, but she has to wait for 5 days. Okay, she has to wait for 5 days. So these are the option if she has come less than 5 days. Now second scenario, when she has come less than 3 days, then in that situation you can offer LNG. But LNG, good thing with the LNG is that she need not to wait for any ongoing contraception. That could be immediate start immediately contraception. Any hormonal method can be started. Okay, so this is if the patient come after less than 3 days, and this is just a sum up. Oral EC is not affected after ovulation. So if your patient is coming and her ovulation date is passed, so in that particular situation you will not offer her oral EC. You will just say it is not affected. Now C for BMI. If your patient's BMI is more than 26 or she is more than 70 kg and your option is going to be LNG, then you have to offer her double dose. Then if your patient is on enzyme inducer, so option will be either copper T or double dose LNG. UPA is not affected here. And if the if this is very important to remember, so UPA as an emergency contraception is not effective if patient is taking any kind of progesterone beforehand, if patient is taking glucocorticoids for control of asthma, and if your patient is on enzyme inducers. So basically your all answers of emergency contraception just will come for this table. If because the guideline has given so many tables, but they be so confusing, just remember this. With this knowledge you'll be able to answer what are the questions that are coming for emergency contraception. Is it clear till now?
Yes, Dr. Priyata, you have
Yes,
made that
ma'am.
algorithm
Yes,
very
ma'am.
simple and easy to remember.
Yeah, with this you will be able to answer. Okay, so this part, this table also you all of you have to remember. This is from strategy. Okay, so just in sum up again. So copper IUCD, you already know it has got two effect toxic to sperm and ovum, and also it has got anti-implantation effect. So it is quite effective. You can give her for 120 days. Now you can see what is the rate. So pregnancy can happen in so less number of patient with the so it has got maximum effect because of its mechanism of action, and also now you can remember that number also. And this number is this slide is from where? It is from this thing, from strategy, so you can remember this number. So less than 1% failure is there with copper T. UPA delays ovulation, and pregnancy will be 1 to 2%. LNG delays ovulation, and pregnancy will be 2 to 3%. So this number you have to remember, because you will get in your question. Even part 3 people sometimes have to explain this number, so they also have to remember. So, and this is from strategy. Now that's all about emergency contraception. So whatever there in emergency contraception guideline, I have put everything. Now with emergency, anyone of you have got any question about emergency contraception can ask me. Otherwise, now I am going to discuss quick start contraception. What is that quick start contraception? That we are with the LNG, we are starting immediately. So that is immediate start of quick start contraception. Okay, so before, till now, anyone has got any question, or should I move ahead?
Move ahead, ma'am.
Ma'am, I have a question. Ma'am, if anyone is taking the underwent that unprotected sexual intercourse on day 11, and she has taken then ulipristal acetate, and again she came on day 19th with the unprotected sexual intercourse, on that day, what contraception I advise?
Only one is left, that is property.
Copper T. Okay.
Yes.
Okay.
Now, what is this quick start or immediate start contraception? So, first of all, quick start contraception is a type of contraception that can be started at any other day in the cycle except first 5 days. Okay, but so whenever you are starting quick start, like for example, I'm starting contraception on day 18, day 19, or any other day. So what will be my first thing? So I have to make it sure that if this patient has any episode of this intercourse is there, so I have to make it sure that this patient should not be pregnant. Okay, so I will do urine pregnancy test. So, and the sensitivity of urine pregnancy test, till the 20 ml U per ml, if the SCG level are there, it will be able to detect it. Okay, this you will also can get any question. And if your patient says, like 3 weeks before, doctor, I had intercourse, so there could be possibility of pregnancy. So whenever we are going to give any contraception, it is as a doctor, we have to be safe in practice. We have to rule out pregnancy first. Then now, if we have got three options. One is copper T. If the copper T is inserted, so she need not to start any kind of contraception, because that is already an ongoing contraception. Now, if our patient has taken EC, oral LNG as an emergency contraception, and in that particular situation, and she says, no doctor, please give me on immediate contraception, I want to start it now. So you can start with CHC, POP, or implant immediately. So today we have given EC, so immediately we can start. We need not to wait for any before we give her any hormonal contraception. But second scenario, our patient has taken UPA. In that situation, what we'll say, okay, you have to wait for at least 5 days before we can offer to CHC, POP, or implant. Okay, so this part have been discussed before also, but I'm repeating it again. Now this part is important to understand. So if your patient how much additional contraception is required. So now here, if the patient has taken CHC POP implant, so and you are starting it after 5 days, so you have to give her additional contraception. But if your patient previously has LNG and yeah, if you are offering LNG after 7 days of her period, then you have to give her additional contraception. Okay, and Clara, and this is Clara and Zoli, these are kind of COC. Only if the patient start these tablets on the day 1 of cycle, then no emergency contraception. Otherwise you have to always give emergency contraception. This so this you have to understand. Okay, so if your CHC, your POP, implant and injection, if they are started with first 5 days of cycle, no need to give any contraception. LNG within first days inserted, no additional contraception. Day Clara started, Clara Zoli, COC, if they are started on day 1, no need to give emergency contraception. But if these are contraception you are starting at any other time in the cycle, okay, like you are and whenever you wish you are starting, so you have to give her additional contraception. This I have discussed before also, I'm repeating everything again. With this, all this, she will require additional contraception of 7 days. With Pop it is 2 days of additional contraception. With Clara it is 9 days of additional contraception. This you have to kind of remember. Okay, so these are the days of additional contraception she would require. Now, what are the contraception suitable for emergency contraception? Only 3 they have given as a choice. One, CHC, POP, and implant. What are not suitable? Not suitable is DMPA. You will not give her DMPA. If she wants to go for a quick start, DMPA is not an option. If she wants to go for LNG IUS, you will refuse. And if she wants to take pill with cyprotron acetate, you will refuse. So just you remember this, only these 3 are suitable for quick start or immediate start contraception. Just remember CHC, POP, and implant. And now why these are not affected? So with this DMPA, the action of DMPA, really nobody can. So it delays ovulation, when the ovulation will come back. So all this thing is not predicted, so it is not started. LNG IUS, why it is not started? Because they are thinking there could be possibility of pregnancy, or again it is inserted for 5 years. Cyprotron, why it is not inserted? If she is pregnant and the fetus is female, so all that complication can happen. Okay, so this just remember this part. So this can be used in emergency quick start contraception. Now it is also important, if patient has started this thing as emergency contraception, quick start contraception, now she comes back and she says, doctor, I am pregnant, then what will be your answer? Then you will say that she can continue with pregnancy. If she wants to terminate the pregnancy, so she can continue with all those method of contraception. But if she says, no, I will continue with pregnancy, doctor, then you will say it's fine. So you have to just stop all these, and then pregnancy can be continued. Okay, there will be no side effect on the baby. Now this line is important here. If your patient is using DMPA and she got pregnant, now she says, okay, I would like to go for medical abortion, doctor. Then in that particular situation, you will offer mifepristone, but there will be some reaction, and chances of failed abortions are high. Okay, so this part you have to remember from here. Now this you have to remember this. You will get a number of questions from here. Now if the intrauterine devices like copper T was inside and a patient got pregnant, so she has come in less than 12 weeks, what you will do? So if the threads are visible and they are in the endocervical canal and they are easily visible, so in that situation, and she wants to go ahead with the pregnancy, so you can very well remove this thread, but you will explain this patient, listen, there will be a small risk of miscarriage. Okay, but if the patient has come after 12 weeks, in that particular situation, whether to remove it or whether not to remove it, you will discuss with her. Okay, because it will be difficult after 12 weeks to remove. So the case has to be individual, on the individual basis, decision will be done. Okay, now if there had been more than 12 weeks and she says, no doctor, I will continue with the pregnancy, then what option, what advice you have to give? So you have to give, okay, you can continue with the pregnancy, but there could be certain risks. What are those risks? There could be possibility of miscarriage, could be possibility of infection, and there could be possibility of preterm delivery. Okay, so this part you have to know very well, because it comes in part 2 also and part 3 station also. So this is very important, pregnancy with copper T. So if the thing is not clear, so please, I can repeat it again. Is the thing clear, people?
Excuse me, doctor. Then, excuse
Yes,
me.
yes,
Yes.
yes.
If it is more than 12 weeks, then there is a possibility of miscarriage and infection, and you told preterm delivery, and also risks of ectopic pregnancy also, isn't it?
No, patient is already pregnant. How
Yeah.
copy can be? Patient is
No,
already pregnant.
if she's on IUCD, or she's on IUCD and she's pregnant, so at the
Yeah.
time the risks of ectopic pregnancy also, the risks.
Yeah, you are right. So whenever a
Yeah.
patient comes with the IUCD in is already inside, we
Yeah.
always will do a scan, because the chances of ectopic pregnancy are there. So we have to
Yes.
rule out that it is intrauterine. That is perfectly fine. But what
Yeah.
I am speaking is about that patient is pregnant. We are considering it is a normal intrauterine pregnancy, and copper T is already there in situ. And if the
Hmm.
same patient comes to you, what will be the options? So option will be like, if she is less than 12 weeks. So if she says, okay, doctor, I want to get it removed. If it is easy to remove, you can remove that copper T, but you
Yeah.
will say there will be small risk of bleeding and miscarriage will be there. So you have to explain it to the her. But
Hmm.
uh, option number second, patient like it is more than 12 weeks, and after 12 weeks it will be very difficult to remove this copper T. So in that particular situation, you have to make the decision on individual basis. But if she continues pregnancy with copper T, okay, in that situation you have to say you can continue with the pregnancy, but small chance, increased chances of second trimester miscarriage, preterm delivery, and infection will be there in your pregnancy if the copper T is already there inside. Is the
Yeah.
thing clear?
Yeah. Then I can say that with this also there is a possibility of ectopic pregnancy also, isn't it?
Um,
Yeah.
See,
After
we are
after 12
discussing
weeks.
after 12 weeks how a topic can be there. No,
No. Okay.
this is what we are discussing now. Patient is pregnant, intrauterine, okay, normal pregnancy, and copper T is there. So how you will counsel
All
that
right.
patient?
Yes. 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 Yeah. Already,
Okay.
if it is confirmed, no need. Yeah. Already
Yeah.
confirmed. Yes. Yes.
Yeah.
Okay. Thank you.
Now, copper T, we have to know about copper T also. It is so important. So what is the mechanism of action? So this again, copper T is kind of contraception that is immediately effected after insertion. So usually there is no additional contraception is required. So it do have a effect on toxic effect on ovum sperm. This is one action. Another action, if the fertilization happens also, so because of the changes on the endometrium, implantation will not happen. Third, what they have wrote this also, that it causes some changes in cervical mucus. Okay, so they inhibit sperm penetration. So why it is important? Because you have to know this, because it can be again a step in your SPAs. Okay. Now this just I put it here. So copper T usually there are so many varieties of copper Ts are there, and they are used for 5 to 10 years. Okay. So and there is one frameless copper T is also there. Name of that copper T is Gynefix. Okay. So this like what to remember here. This just I put it here, just have a visual impression. Now, if the copper T, it can be inserted, any time in the menstrual cycle. And good thing about copper T, no emergency contraception. So it is an emergency contraception. No additional contraception will be required. But where you will not put it, it can be also put a post-abortion or post-delivery within 48 hours or after delivery 4 weeks. Okay, this we already know. So either it is inserted when the patient, before we discharge patient within 48 hours, or if patient has gone back, then we have and she says, okay, I want to go for copper T, then you have to say, please come after 28 days of delivery or 4 weeks, and no additional contraception with copper T ever required. Then this part we have done last class also, but it is so important, I have put it again. So whenever you are putting any copper T or any IUCD inside, you have to do risk assessment. So sexual history risk assessment is there. So who are the people, those who are at a very high risk of STI? If the young people less than 25 years of age, new sexual partner in last 3 months, more than one sexual partner in last 1 year, having regular sexual partner, but this sexual partner has got other sexual partners. Okay, so and whether previous history of STI is there, she is attending as a previous contact of STI, or any alcohol and substance use. This is STI risk assessment is very important. For part 2 people, you will get this as a scenario. So patient is taking this is in substance use and she has got that much partner. So this is kind of STI risk assessment. And this part in sexual history also we do for the part 3 people. So this is very important slide. Not before copper T, you do some checks. What are the check? You will take medical history and medical history. Why you are taking? Because you have to rule out which category this patient belongs to. Sexual history for STI risk assessment. So if this patient has got if patient is asymptomatic for STI, she has a history of STI. Now she's not showing any symptom. So what you will do? She says, okay, doctor, I want to go for IUCD. Then you will say it's fine. So you in that particular situation, you will take swab and you will put IUCD inside, and you will explain to this patient, okay, if your test come positive in that particular situation, we will call you back and you would require antibiotic. So the take home message is that if the patient is asymptomatic, on your STI risk assessment, you found that this patient is at risk, but at present she has got no symptom. So you will take swab, you will put copper T, and you will counsel her. In case a swab test come positive, she will be contacted. She has to come for antibiotics for STI. Okay, with this time you will get a number of questions. Is the thing clear?
Yes, clear.
Benefit of IUD, I found only one. You have to remember, for part 2 people, you have to do copper IUD associated with reduced risk of endometrial and cervical cancer. And I don't know how it protects against endometrium cancer and cervical cancer, but it is important to know because it could be one stem of your SPA. Now you will get question from here. If the bleeding is there after insertion for 3 to 6 months, there could be irregular bleeding. So, but it improves with time. So usually you will assure this patient. Okay, you will assure this patient only. Now, the IUD and ectopic pregnancy. So usually if the pregnancy happen, there could be high possibility of ectopic pregnancy with if the IUD inside. So now if the patient has IUD inside, she missed her period, so and her pregnancy test is positive, so you have to just scratch your head. Okay, I may be dealing with ectopic. So what will be your first action? Please arrange for ultrasound scan urgently. You will get a scenario in your exam, IUCD inside, pregnancy test positive. So what will be your first action? Answer will be urgent ultrasound scan to rule out ectopic. Okay, so someone was asking this question, so I think now it would have been answered. Now this you have to, these numbers are very important, you have to learn it. So risk of expulsion is there 1 in 20, and it is more particularly within first 3 months. Okay, so this is important number to remember. And risk of perforation while putting copper T inside is 2 in 1000. 2 in 1000. All these numbers are important for your questions. And it is 6 times higher perforation. Why? In breastfeeding women, because of this thing, because of involution of uterus, smaller size of uterus, like very chances of perforation, because assessment of that uterine length will become difficult. This is also important when the cervical stimulation happens because of during the insertion of this intrauterine device. So sometimes vasovagal can happen, bradycardia can happen, other arrhythmia can happen. So if your patient is a healthy woman, in that situation you have to start with the basic resuscitative measures. Rarely, if the bradycardia is not improving, in that situation you have to offer her intravenous or intramuscular atropine. You will get this as one of your question. So you are inserting copper T, all of a sudden your patient collapsed. Okay, so one question will be like what is the diagnosis? Your answer will come vasovagal reaction. And another question can come, so what will be your first step? Your answer will be A, B, C, resuscitative measures. Third question, what is a drug of choice? If bradycardia persists, your answer will be intravenous or intramuscular atropine. Okay, so this slide is also important both for part 2 and part 3. Is the thing clear? Is the thing clear?
Yes, very clear.
Now, sometime you will get in scenario patient has, because copper T is in foreign body, so there could be recurrent bacterial vaginosis can happen, or recurrent vulvovaginal candidiasis can happen. So if recurrent episode is there in that and patient is a copper T user, so you can say, okay, she can consider another or alternate method of contraception. Now before insert of usually when the IUCD is inserted, so guideline does not support any local lignocaine or any NACID that will improve insertion or reduce pain of insertion. Okay, but what the guideline says, if the like insertion is difficult and you have to dilate her cervix, in that before dilatation, local anesthetic can be given. Okay, though it is not a routine. Okay, only if it is dilatation required, before insertion you can offer her local anesthetic. Then this question you will get in the many times. Patient has bleeding, she has IUD copper T inside. What you will give? You can give her NACID. NACID is a mechanism, is you will only give if this she has problematic bleeding, and if she says I'm having pain after insertion, then also you can give NACID. So 2 times answer will come NACID. Now this is, you will get a number of questions from there. ALO is actinomyces like organism, and IUD. So usually this actinomyces Israeli is a common commensal of vagina. So it do have association, like it is a foreign body. So there could be like it will sometime when the smear is taken, you will find ALO in the smear. Okay. Now if the patient it is there, and if the patient is asymptomatic, in that situation you will get an option, should the IUC should be removed? Answer will be no. So with asymptomatic ALO, IUCD removal is not recommended. You will get this as a question. Okay, Now, if the patient ALO is there and patient is symptomatic, and so with the symptoms, consideration for IUC can be given. So take home message is that with asymptomatic ALO, no removal. With symptomatic, you can consider IUC removal. But after that, if it is symptomatic, you have to give her high dose of antibiotics, and also you have to take advice from microbiologist. So you will get, you may sometime will get this as a question as well. Patient with PID, you will, this is also famous question. So if the patient has a PID, and usually what we give them treatment. Okay, IUC removal is not done routinely, but usually with the PID patient, we call them back after 3 days. If we find that there had been no response, this patient is worsening, in that particular situation, we can we can remove her IUCD, but we will but if she has got intercourse last 7 days, because today I'm removing it, and if she has got intercourse last 7 days, she is at risk of pregnancy. So if the criterias are fulfilled, I will offer her oral EC. This part is very important. You will get question from there, or this slide. Part 2 and part 3 scenario also comes active PID patient with copper T. Is this slide clear? Should I explain it again? Is the thing clear? Active PID and copper T inside. Clear? No question. No, yes or no? Okay, yes. Good.
Clear, ma'am.
Okay, fine. So my saying repeat. Okay. Now, if the patient has presented to your clinic with PID, she has got copper IUCD inside, please give her treatment. Don't remove it. But usually we call this patient after 3 days or 72 hours to see how they are responding. If you find your patient is not responding, and she has, her symptoms are not improving, or PID symptoms are not improving, then in that situation, what you will consider, you can remove her copper IUCD, but you will take history from her. If she whether she has got unprotected, whether she has got any kind of intercourse. If the intercourse, if she give history that, yeah doctors, I had an intercourse 3 days back, or I had intercourse 5 days back, in that situation, she once you remove copper T, there will be risk of pregnancy. She will fall pregnant, so you have to protect her from pregnancy. You have to give them oral EC. Soma, is it clear?
Yes, Dr. Priyata, it's very clear.
Hello.
Yeah.
Sorry to interrupt you, ma'am. Is the PID and ALO is separate? Will they mention that in the question that it is ALO?
Total different thing.
Yeah,
PID will
okay.
be there because
Chlamydia and gonococcus.
yeah.
Okay.
You got it.
Okay.
Yeah.
Yeah.
Totally
Okay.
different thing.
Okay. Okay. Thank
Follow up after IUD, usually after first menses, or 3 weeks after insertion. Okay. Then this IUD and cardiac disease. So you will get this as a question. If the patient is having cardiac disease, and she wants to go for IUCD, in that situation, insertion will be done in a hospital setting. Why? Because we have just read that because of this dilatation, sometimes vasovagal reaction can happen. And if you do it outside, then in the patient who are having single ventricle circulation, Eisenmenger syndrome, and in that particular, these are the few tachycardia or pre-existing bradycardia. If something goes wrong and vasovagal reaction happen to this woman, you will not be able to handle it in the clinic. So for all these patient, cardiac patient, all this situation, in presence of cardiologist and also in the hospital setting, copper T can be inserted, should be inserted. So you will get this also as a question. Now, now I'm moving to another topic. So is the thing clear? Should I move ahead?
Yes, please.
Okay, young people and contraception. I can't help it. I have to cover a lot today. Okay, so young people, what the young people, usually less than under 16 years age girl, these are the young patients. So before, though you already know this, even for part 3 also this part is important, because part 3 also in the station they have to do this. So you have to assess competence. So what you will assessment of competence. So if they can explain what what type of treatment is there, what is purpose, on what is it is nature, and why this treatment we are giving to them. If they can understand risk of the particular procedure, benefits and alternate, and if they also can understand what could be the consequences if the treatment will not be taken, if they can understand the procedure, risk, benefit, alternates, consequences, and after that if they can retain all this information in their head, then they can decide for themselves and they can come back to you. So this is the assessment of competence. Okay, so it is important, because you will get in part 3 station you have to do it, in part 2 you have to answer it. And also this part you have to remember, there is a Fraser guidelines or Fraser criteria. So like, what is a Fraser guideline? This Fraser guideline is for under 16 contraception. So according to this guideline, if under 16 girl is coming and she wants to go ahead with the wanted contraception, so you can give her contraception. So what are these guidelines? Like according to this guideline, we always encourage them so that they should inform their parents. But if they say, no doc, I don't want to tell my mom, then in that situation you cannot persuade them to inform their parents. Okay, this is one thing. Then in part 2, this is a very famous question. Answer is encouraged to inform parents. Okay, then young patient, if you think that this if you don't give contraception, this patient will going to have intercourse. So you will assess her from the history, and if you think that she will not she will continue to have intercourse, you have to protect her. Please give her contraception. Second, if you don't give her contraception, her physical mental health will be affected. Okay, then also you have to give her contraception. And whatever you are doing, it is it in her best interest. So with or without parental consent can be given. Okay, so these are the Fraser guideline, important for part 2 and part 3 both people. Is it clear? Fraser guidelines, this is for this is for contraception under 16. Okay, very good. Now again thing is confidentiality. What is this confidentiality? Confidentiality is right to privacy. That means if the patient comes to me in my clinic for any kind of treatment, I have got a duty of confidentiality. Whatever she has told to me, whatever treatment I had given to her, I cannot share that information with anyone. So when the young girl under 16 girls are coming for contraception, we have to say whatever we are discussing here is confidential. Nobody will have any like access to information what we are discussing today. Okay, apart from this, if your safety is an issue, for example, like if the 15 years old girl is coming, you take history from her and you found that there is a person who is like sexually abusing many of her friends or many of her other girls, then in that particular situation, safety of so many other girls is at risk. So this is a situation you will breach her confidentiality. Okay, because always confidentiality assurance is there, but there could be some parts are also there where this confidentiality can also be breached. So in part 3, whenever we do under 15 station, we always say whatever we are discussing is top confidential. I may need to involve my colleagues if I found your safety is at risk. Okay, so this part is important to understand, is confidentiality. Now safeguarding, if the young less than 15 girl is coming or 16, you know why they are sexually active, why they are coming for contraception. It is not that she has come to you and you will just give her contraception, okay, take it and enjoy sex. No, it is not like that. You have to find it out why she is sexually active. Someone is exploiting them, or any she's under any pressure, any sexual abuse is going on. So all this situation you have to assess. In part 3 we take all this history of safeguarding history, and then in their hospitals there is a policy. So whom to be contacted if the child at risk, and usually they have got a child protection midwife is there, or local lead for child protection is there. So if you find any under like safeguarding issues are there, so you have to contact like a local either child protection midwife or local lead for child protection. So this safeguarding will also a part of your station, or also it is important in under 15 girls. Okay. Now consultation under 16. So this is also, so this what they have written in guideline, that is too very good. So first of all, whenever this girl is coming, you have to explain her confidentiality. Second thing, you should not make assumptions about her sexual behavior, why she's coming, about her age, gender, disability. So in part 3 we say that there should be like non-judgmental approach. So this is non-judgmental. You will not judge them that for their behavior, their visit, their like and sexual contact, anything. You will not judge them. Okay. And also you will not moralize them. You will not give your moral values for sex, sexuality, contraceptive choice, all this moralization, moral values you will not give. Like in our country, if the young girl is coming, we as a doctor also we became their parents and we gave them some moral advice also. But in UK, no moralization should be there about sex or sexuality or anything. So these are the few things I just found good in guideline, therefore I put it here. Now, for UK MAC category, for young girl also, the criteria will be same. Okay. And usually all type of contraception can be given to them as well. Even the LAR can be given. And if, whenever you are giving a contraception to young person, so you will call them after 3 months. Okay. Follow-up is there for 3 months. Why? Because you have to find out whether they are using it properly, and whether like any concern is there or any side effect is there. Young people, you have, if DMPA that you already know, we discussed last class, if you're offering them DMPA, you will say that there could be possibility of weight gain. Weight gain can be there, that will be 5%, and if the BMI is more than 30, so you have to kind of explain this to younger. Rest all other contraception is same for adults. Categories, side effects, risk, benefit is totally same. Then young girl, again they are very worried about their acne. So you will find a number of questions for this acne thing. So you can say with some COC, usually acne improve. Now if the girl is coming and acne is not improving, and she wants to continue with COC, what will be what you will say? Either you will give COC who has that has got less androgenic progesterone, or one that has got higher estrogen. From here you can get a question. So it is important to remember. Second, if the too much of acne is there, so this pill Dine 35, that is the pill that contains cyproterol acetate, that can also be offered. But usually it is given for 3 to 4 months, not much, because it do have got high rates of VT embolism is there. Again, with the implant, whenever you are giving them, you will explain with some of the girl acne will come, some it will worsen, and some it will improve. So this kind of thing with acne, whatever the contraception you are offering them, this acne advice also has to be given. Okay. If you say that your acne is going to worsen in young patient, they will refuse for implant. This part we have already discussed. So usually we don't offer them DMPA because of the because of the loss of bone mineral density. So if like that, we ask them to use any other contraception, but if they still want to go ahead with this, we can offer them. But in that situation, we have to review them after every 2 years. Okay, because of this more bone mineral density thing. Then again, this is very important. whenever anyone is coming, safe sex practices you have to explain. Contraception cannot be done without safe sex. So usually you will find a question where the young girl come, so you have to give them double contraception, that is called as a double Dutch method. You will give them reliable contraception plus condom, safe sex practice. Okay, now whenever, so this is the safe sex practice explanation. Again, if you find young patient has come to you and she is at a risk of STI, so you will do her STI test 2 times. So one will be done at 2 weeks, one will be done at 12 weeks. This part can come as question, so you have to remember it. Why we are doing it doing at 2 weeks? Because all this chlamydia, gonorrhea, chlamydia usually it will not appear in the test. If the today contact has taken and she has got chlamydia, she will, if you take swab today, you will not get any result in that. Usually it will take time to appear in the test, so it will be 2 weeks. So we are doing test for STI 2 weeks. 12 weeks you already know it is for HIV and syphilis. It takes time, therefore STI testing is done 2 weeks and 12 weeks. Any question with young one, or should I move ahead? This is you must be people must be getting bored, so only one topic is left. Should I move ahead? Okay, so contraception over 40 years. So why I have put it today, because we are discussing young one, so better to complete that do it contraception over 40 years also. So a few things I will explain here, not too much is there for 40 years of age. So 40 years of age, and if you are prescribing COC, what you have to remember, you will give COC that has got less than 30 microgram of ethinyl estradiol. This is one point to remember. Second point to remember, you will give them COC with having progesterone component as LNG or norethioestrone. Okay, and CHC is a contraception. We have to stop at 50 years of age. Okay, this slide I have shown it before also. You have to remember this by heart. All numbers are very important. Here now you can see, with if the ethinyl estradiol is given with levonorgestrel, then risk of embolism is 5 to 7 per 10,000. But if any other progesterone you are giving, so there is a high risk of embolism. Therefore 40 years of age is a risk factor, so we want to give them COC with less estrogen and with levonorgestrel or norethioestrone as progesterone. Okay, now CUT, if the patient at 40 years of age CUT has been inserted, so it can be extended till menopause. Okay, now these few things again are important. So if the CUT is inserted, extended at the 40, so now she can keep it till menopause. And if she is less than 50 years of age, so after menopause, as the contraception is required for 2 years, so she can under 50 property she can keep 2 years after menopause or last LMP. If she is more than 50 years of age, after 50, contraception is required only 1 year, so she can continue it for 1 year more. Okay, you may get question from there also. Now this LNG IUS after previous class also, so many queries were there. So a few things you have to explain about understand about LNG IUS. So LNG IUS, if it is used for contraception, if it is used for HMB, then usually it is licensed up to 5 years. Okay, then a second thing, this is the question also we did last week. So if marina coil or LNG is used for endometrial protection, then it is licensed up to 4 years. Okay, so this thing is about license. So one thing is license, like this license is given by that SPC, like manufacturer advices are there. This is license about that. So in UK, this thing is according to license. Another thing, what we do as a clinician is a practice. So these two things are different. What is license and what is practice? And you will get question from both. So I'm repeating it again. Mirena coil is licensed for contraception and HMB treatment for 5 years. That means after every 5 years, you have to change it. Second thing to understand, you want to use this as an HRT because patient is taking estrogen. So you are supplementing estrogen and you want to protect endometrium. If you want to use this for protection of endometrium, it is licensed up to 4 years only. So this is about license thing. Now come to practice thing. So for practice thing, we for contraception, HMV and HRT, we usually change after 5 years. But if this patient only one indication where extended use can be done, that is for contraception. If this patient is using Mirena coil for contraception, in that particular situation, extended use till 7 years can happen. No voice, madam. You people can hear me or not? Hello?
Yes, yes, can hear.
Yes, ma'am. Yes, ma'am.
Yes, we are hearing.
Okay. Is the Mirena thing clear or not?
Yes, clear.
Absolutely. Yes.
Yeah, because after last class there was so many queries. Now, therefore, I have put it here.
Hello,
Okay, so this.
hello.
Yes.
Madam, the last slide, please. It is written here that until the age of the 55, if inserted at the age of 45 or over. So until 55, we can keep the same Mirena, or we have to change it again?
You have to change it. If you you have to change it.
If
Yes.
Okay.
Now there is a table will come. Just wait. Now this is also important. So when contraception is not longer required, so if the patient is taking progesterone contraception, then we will not know. So to know whether the menopause, the patient has been through menopause or not. So what we do, we usually do FSH. If FSH is more than 30, that means menopause is has been confirmed. Okay, in that particular situation, if she is less than 50, give contraception for 2 years. If she is more than 50, give contraception for 1 year. Second, this is one thing to understand. Second thing, if your patient is taking CHC or HRT, in that particular situation, you after like the levels of estradiol will be suppressed, or also this FSH will be low. If the patient is taking the CSC and HRT, then no hormone test can give you this thing, any information whether the menopause is there or not. So what you have to understand, if the patient is only progesterone only contraception, then only to diagnose ovarian failure or menopause, we can do FSH as a measurement test. Okay, because you will get question from there also. Now this part of the table you have to understand. So just remember these two things, CHC and DIMPA. These are the two hormonal contraception that till 50 it can be used. Just remember two contraception, CHC and DIMPA, change it by 50. All these contraception what are written before, they can be used till 55 years of age. Why they can be used for till 55 years of? Because what it is assumed after 55 no contraception is required. Okay, so this much you have to understand. Just remember only two things, CHC and DIMPA. If the patient is using and she is 50 years of age, you have to kind of stop it and switch over to another one. Progesterone you can use till 55. After 55, there will be natural loss of fertility. Fine.
Madam, last slide. In the last line, it is written that it can be remain in situ.
Yeah. So if now, let me explain this also. If the patient LNG IUS is inserted at after 45, okay, or at 40, and she wants to continue it for contraception or HMV, then it can remain in situ till 55. Okay.
Okay.
Because
Okay.
Marina can be kept till 55. Yes.
Yeah. Okay. So more than 7 years, it will become, madam. Then.
Yeah, it will become, but for contraception, it can be used more than 7 years. Yeah.
Okay. Okay. Thank you.
And after, if the menopause is there, HMV will not be there.
Yes. Okay.
Okay. This part is important to understand. If you are using this Marina coil for endometrial protection, you have to change it 5 years. Why you have to change it 5 years? Because you are offering estrogen from outside. Okay, in that situation, if you don't change it, so after Marina coil after 5 years, so in that particular situation, what will happen after 5 years? You already know, we did it in last class. Marina coil, it just releases 20 microgram of progesterone. After 5 years, it will decrease down. And if you are given estrogen as an ERT, and then she will have less amount of progesterone to protect her endometrium. So you cannot use this for a longer time than 5 years. So if you are using this LNG for endometrial protection, you have to change it 5 years. Is the thing clear? Is the thing clear? Okay. Now my part is over and your part comes. Now it will, any question you can ask me, otherwise now there will be the questions only. So if any part 3 people are sitting here, they can leave, because now there will be the questions for part 2. Okay, no question, then now you just scratch your head. So this is question number 1.
Hello.
Yes,
Hello,
yes.
Dr. Priyata.
Yes.
Sorry, I have one question. Very silly question, but come in my mind. Can I ask?
No question is
For
silly. All questions are always welcome.
Okay, thank you. For emergency contraception, means if patient come within 24 hours or within 3 days, and she is suitable for total 3 option like COT and UPA and LNG also, and she want to take oral emergency contraception. If she ask, then which is better for her, either LNG or Ulipristal? Then what should we say? That is
UPA.
UPA.
It is more potent.
UPA.
Yeah.
Yeah. Why is more potent for the?
Yes, it is more potent.
Only this, no?
Yes. Yeah.
Only this, no?
Yeah.
Okay. For this reason also, yeah. Okay. Thank you.
Yes.
Thank you. Yeah.
Okay. Fine. Okay, so this is for this question we have done in class also, but I have put it again. So now the property is there, and she have a like 4 months after property, she is having spotting and bleeding. She was frustrated, wants to remove the device, whatever she wants to do. So what you will do? We just read, like, with the copper coil, it may take 3 to 6 months for bleeding to settle. Okay, so answer will be, I think, C here. Reassurance and reassess in 2 months if bleeding continues. Someone wrote E also. So E, why we are not putting E as an answer? Because they in the question they have not given any high risk behavior, or she's a old patient, her age is also like not for infection type of thing, so therefore infection is not there also. If they have not shown that there could be cervical pathology, because if the cervical pathology they show in the question, like she missed her smear or abnormal smear, in that particular situation E will be the answer. Okay, but right now this patient from the question does not appear set as a risk, and also not giving any indication for cervical pathology, so answer will be C. Okay, so answer is C, reassess in 2 months time, because first 3 to 6 months we read it just now, bleeding is common. B. Answer is E. Why they have removal of IUD may be considered. This patient is a symptomatic patient. Therefore, removal of IUD maybe should be considered, may be associated with better outcomes. But answer D could also be there. Yeah,
But
because
D also up to 72 hours it is given. The PID
yeah,
guideline 48 hours, 48 to 72 hours, but in the this guideline it is given 72 hours.
72
So
hours.
I am not able to.
Ma'am, B option, it is until the course of antibiotics. It meant 72 hours, no?
No, antibiotic is given 14 days. Antibiotic course of PID is 14 days. Doxymetro 14
Okay.
days. Okay. So B is
Okay,
not
ma'am.
an question at all. B will not come. And so D and E are the confusing things, options there. But you know, D can be there. D can be there, but again they want it at 72, so they have put it E as an answer. Nikki, acute PID insertion is UKMAC4. Okay, if you insert it at this condition, that will be UKMAC4. Here you are not inserting, copper is already inside. Fine. Like according to their guideline, you can give them antibiotic. You have to reassess them after 72 hours. If she is not improving, so you can consider for IUD removal. But if she has got intercourse last 7 days, you have to consider for EC. So this is their guideline. Just remember their guideline thing. According to that, you answer your question. Here, this book has written answer E, but D is also like I will put D. So this is also a very good question. We just discussed. Very good. Pratik and Junatha, we have done this question in the class also. Yeah, it is right. Who write E? Madhu, you are not listening in class. If she is on COC, any hormone level check will not give any good result. Okay, we just read FSH level can be checked only with POP only. Fine. So in this situation, answer is B. We had a discussion in the class also. So why B? Now I'll explain you this. So to change her to another method, At 51 years, why you will want to give them Marina? Because that will be for 5 years. So this option A is gone. Come to C, continue this for another 2 years. But after 51, contraception is required for 1 year. And also at 50, COC has to be stopped. So C cannot be answered. Estradiol check, estradiol check has got no significance. FSH check here has got no significance. FSH check is only done in case of progesterone. So left out answer is answer B, that is changed to barrier method. Okay, so this is the explanation. Now you read this question. Then I will show you options. Okay, so have you read question? Then this is the option. Should I show question again? So read this question well. Now these are the options. Yes, very good. Answer is B. Very good. Answer is B. Fine. Now you read this question. These are the options.
Question, please, ma'am.
Yeah.
Question, please. Question, please.
These are the options. Yes, very good. C is an option. Yes, very good. Copper coil. Very good. No contraindications. Read question well. You know, the option girls case should include all of the following except which one? Except is there. Yes, A is the answer. Okay, A is the answer. It is not necessary that she has to disclose this to her mom. Very good. Read this question. So once this question you have read, these are the options. So question yes, good. Answer is H, copper T and UPT. Yeah, very good. So now this is the question. Read question. So this is the question and these are the options. So don't think levonorgestrel 2 tablet. Previously this 2 tablets they used to give because it was 75 microgram. But just you think the 1 tablet only. This patient has ITP and also she has ITP. So and also she is on long-term steroids. Okay. So ITP. Yes, D could be the choice. D could be the choice because according to recent guideline, they have not given that in ITP copper T should not be inserted, but the answer is levonorgestrel. Okay, recent guideline they have not told anything about this thrombocytopenia thing, but the
Ma'am,
answer
here
is
it is 14 days after periods, no? Then how we can give levonorgestrel? 2
periods
weeks
2 weeks.
ago.
Yeah, you are right. Actually, yeah, this question is old question, you know. That time this concept was not there. Okay.
Okay, ma'am.
Yeah, this concept has changed after 2017 and question is old. Okay, they have said that copper ICD should not be given because of menorrhagia, because ITP also they will have bleeding problem. Because of this bleeding, if the copper coil is inserted, bleeding will be there. Fine. Okay, so this is the question. Nali Pera, she has got intercourse with stranger, cycle is regular. Her last period was 2 weeks ago. Okay, what is most appropriate step? Yes. Whenever Junetha, whenever you find any stranger in the question, unprotected intercourse with any other person, please think of STI always. Okay.
Okay, ma'am.
So yeah. but that is
Okay,
must.
ma'am, but here levonorgestrel it won't work at the time of ovulation. No, here it is 14th day.
Okay. Yeah, you are right, but this is old question.
Okay, ma'am.
Okay, answer is L. So again, you have to find out in all other options. Only this has got full STI screen. So stranger intercourse option with this will only come.
What could be the best option, ma'am? Best answer, ma'am. Answer.
In this particular situation, it has to be this STI prophylaxis or STI screening plus copper T. This will be the
Copper
best
T.
answer.
Okay.
But here,
Okay, ma'am.
that choice is not there. So answer becomes this. Also, this question usually is from before this new guideline came.
Okay, thank you, ma'am.
Yeah, this is a good question. So should I show the? Now she has got intercourse 40 hours ago. That means 3 days ago. 2 days ago. Periods are irregular. She's using condom. Okay, what will be the first choice? What you will think? Reassurance. Why? How you can do reassurance? HS, copper ICD, and pregnancy test within 2 weeks time. Her periods are irregular, you know. So you cannot find out whether what to give here. This is first thing. And she her main method is regular male condom. So there could be a possibility she is already pregnant from previous any episode, because this male condom has got no reliability. Fine. And she is unsure of her period because these are irregular. So what you will do? You have to rule out pregnancy here. Answer is N. H is what? Okay, copper IUCD. Why we are not giving any copper IUCD or any other option here? Because her
One
periods are
I, ma'am.
I
LNG tablets and pregnancy if that.
because you know we don't know about her periods. Anything it is irregular. She's unsure, and she's not using any reliable contraception. She's 19 years old. So if the periods are irregular, okay, in that situation, and if they have got any previous episode, there could be possibility of pre-existing pregnancy. So this is again safety point also. We did it there was a slide like if we have to make it sure that she is not pregnant from previous episode of intercourse. So with the male condom, what the scenario shows, she's 19 years, so she's a high risk behavior girl. Second, she is using a male condom. So and periods are irregular, there could be possibility she is already pregnant because she is not sure of her period. So if surety is not there, you have to find out whether she is not pregnant. In our clinical practice also, if the patient is not sure of her periods, and before giving any hormone, you know, we always check pregnancy. So same thing is there in this question also. Now easy questions are coming. She does not want children. for at least 5 years. So UPA, UPA will not be the answer, because it will not give other protection, or this will not be the C, D, E cannot be the answer. Someone has marked B. Why B? Copper coil is itself a contraception. Why you want to give her hormone? Answer will be copper coil, because it is a best emergency contraception. It can be kept for 5 years without any other hormonal thing together. So answer is A.
Excuse me,
Yes, yes,
ma'am.
yes.
That one, it is not, nothing is given for the regarding the period. So we don't know, she might be pregnant. So oral, if given the oral, if it is the positive, then we can choose regarding that. Because of that, I choose the ulipristal. Because period, regarding the period, nothing is given there.
You are
What is the
right.
day of the period? Yeah.
Yeah, nothing is given, that you are right. But if you like, if they have not mentioned anything, so you can you can think that she has a regular period.
Oh,
Like in last question,
Excuse me, ma'am.
in last question they wrote it irregular. Okay, she was not sure, so you are also not sure. But in this
Ma'am, excuse
patient,
me, ma'am.
yes,
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 regular, madam. But what is the day of that UPSI? We don't know, no, madam. So
she
how
said
can
3 days, 3 days later. So 3 days later, only two choice you have. After 72 hours, she's coming after
so
3 days.
that is why I choose the Uliprestol, ma'am. 3 days is over, so that's why I choose the Uliprestol, because
Yeah,
nothing
but
is given there. That which day, nothing is given. So it might be some 20th day or something like that. If it is there, then if copper coil is given, it may do some harm to her. Uliprestol, if the pregnant test become positive, then we can she can choose regarding the option of whether keeping or not.
yeah, that way you are right. But like your concept is right, clear, But
Okay,
again,
okay,
if they have not given periods, so we will
uh,
think that this is regular period. And
okay.
like after 3 days, there are two options. One is UPA, another is copper T, and she
Yeah.
wants contraception for 5 years. Therefore,
Yeah,
copper becomes
yes. Okay, okay. Because 5 years
Ma'am,
we
excuse me,
have to
ma'am.
choose couple.
yes, yes.
Ma'am, the previous question, ma'am, the 19-year with irregular cycles,
Yeah.
the scenario is same as what we talked some time back, that multiple upsee, the person does not know when the last upsee was there, that whether she was pregnant or not, and doesn't remember anything. In that case,
Mm.
it was told that first choice would be an oral EC, because if at all pregnancy happens, nothing will harm. Can that be applied here also? Oral EC, why not oral EC? It is similar to
But
that multiple
That's
upsee
why
episode,
I
no?
chose that I
but in that,
LNG.
yeah, but in that slide also, do UPT was there.
Okay, ma'am.
Okay.
Uh,
I will send a screenshot of that, because I have to go too much back to that
okay,
slide
okay.
also. If it is like UPT was there, I will send
Uh-huh.
screen.
Okay, ma'am.
So now this is the second question. Yes, E is the answer. Here now she has got epilepsy. Yes, she's with the enzyme inducer, double dose LNG. This is, I think, is the last question or what? Yes, A, Gallic Chem's competence. Why? Why implant? Why implant?
Because infection is there, sepsis is there, and after that again the DNC done. So how can we put the copper device, ma'am?
Yeah,
So
so
and
that's
18 years
the
old,
question.
18 years old.
That is the question. Which of the following is unacceptable health risk? So they are asking which of one is the category 4.
I'm sorry, ma'am. I'm sorry. The last line I didn't read properly. I'm sorry.
This is the mistake. That's why
Yeah.
the mistake. So answer is
I'm
copper.
sorry.
So it is sepsis. That is
Yeah,
category
yeah.
4. Okay. Okay. So with this, any one of you have got any question can ask me. Any question?
That madam, that